I was asked to talk about devices for the right ventricle, and I put this in the context of my counterpart for VA ECMO. But I just wanted to basically highlight the fact that this field of hemodynamic support is driven primarily by our utilization of hemodynamics. Is that better? Okay, great. So I'm going to talk a little bit primarily about another data-free zone, and part of the reason why we don't have data is we don't collect the right data. And I think the field of cardiogenic shock needs to completely revamp itself in order to acquire the correct data so we can change outcomes. So I thought I'd start by just showing you what our approach to cardiogenic shock has been at Tufts Medical Center over the past 10 years. As you can see here, this algorithm that we put together for the management of acute mechanical support or implementation of acute MCS and shock begins at the very top with the use of a PA catheter. So back then, I think this is probably one of the most important interventions that an interventionalist can do when trying to manage cardiogenic shock. And the reason for that is that if you use a PA catheter, hopefully you know how to use a PA catheter, and it's not about just technically implanting it, it's what to do with the data. And so for all of these patients who come in, we want to confirm, of course, that the cardiac index is less than 2.2. But then how do you stratify patients in cardiogenic shock? Is all cardiogenic shock the same? And the answer is no. As you've heard from our colleagues, that there's all sorts of AMI shock, there's underlying comorbidities. But even just from a hemodynamic perspective, one of the things that's lacking from all of these clinical trials that you've seen is any hemodynamic stratification of cardiogenic shock. And so if you were to simply take the cardiac index, and you know it's less than 2.2, and then you look at the congestive profile of that patient in cardiogenic shock, you'll start to unearth various profiles and different types of cardiogenic shock. You'll find patients who are hypovolemic. You'll find patients who have LV dominant shock, where the LV is congested but the RV is still functioning. You'll find patients with RV dominant shock, although that's less common. And you'll find patients with biventricular congestion in the setting of cardiogenic shock. And so using that stratification theme, we go to the next level, which is to implement another hemodynamic formula to ascertain whether the RV is failing or not. And that's the pulmonary artery pulsatility index. And if that index is less than 1.0, then we know that we have pretty profound RV dysfunction in addition to cardiogenic shock. But the red zone is where the RV gets involved. So if there's RV dominant shock or biventricular involvement, this is where things can get very complicated. The device options are shown here. You can think about LV support. You can think about Impella tandem. You can think about biventricular support with Bipella, VA ECMO with a vent. You can think about tandem bivads, depending on what your institution is doing. So we'll talk a little bit about how we manage the RV in the setting of cardiogenic shock. So one of the most important things I learned is introspection. And so we went back to our data set at Tufts Medical Center, looked at all of the hemodynamic profiles of patients coming in with cardiogenic shock who are either getting Impella or ECMO. And what we found was that when you stratify this scatter plot, these are all patients with cardiac index less than 2.2. Patients can be put into 4 quadrants: euvolemic, LV dominant, biv, or RV congestion. And the majority of patients are falling in the upper right quadrant where in fact they have biv involvement. So if you take biv involvement, isolated RV involvement, the vast majority of patients in cardiogenic shock are not in univentricular failure. They usually have some component of biventricular dysfunction. And I think this may be changing why, how we use the devices and how we manage these patients. So I'm going to put together I put together a case primarily to illustrate some of the points here. And I just wanted to ask, we've heard a lot of things that the interventionalists do, but if you take off your interventionalist hat, how many interventionalists here manage these devices after they leave the cath lab? So do you go to the unit, you're rounding on them daily? How many here rely on an intensivist to take over? How many here use a heart failure specialist? Heart team approach? Okay, good. So I think, the putting in the devices is one thing, and now the question is the real work begins after the device is in. And that's managing the patient in cardiogenic shock with a hemodynamic support strategy. So here's a 60-year-old patient with a recent upper respiratory viral illness, comes in with, rolls in for an NSTEMI, right heart cath, showed cardiogenic shock at an outside hospital. Cardiac power output is 0.4, POPI is less than 1 at 0.3. Patient gets an Impella at the outside hospital and is transferred for further management. So on arrival, you've got somebody who's got a blood pressure that's sustained on multiple pressors and a CP device. They're oxygenating just fine. They are intubated, so the FiO2 is at 40%. The first thing we do is always feel the feet, and we know that this patient's pretty clamped down. We look at the echo, EF is 10%, you've got severe RV systolic failure. So let's get some hemodynamic data. And so we've got dobutamine, Levophed, Epi, Impella 2.1 liters per minute of flow. RA pressure is 13, wedge pressure is 18, index 1.2. The RA wedge pressure ratio we use to evaluate the RV is already above 0.6, and the POPI, as we said, is less than 1.0. The lactate is 10. So we know that we're in a pretty profound cardiogenic shock low output state. So what's an acute MCS specialist to do? So we look at the echo. This is the echo with the Impella in. You've got some contractile function, looks like an edematous thickened LV here as well. These were the hemodynamic data we just saw. And so the question for this patient, where we know we have biventricular failure, the RV is profoundly involved here with elevated biventricular filling pressures and a low pulsatility index, is should we do Bipella or do we do ECMO? How do we support the right ventricle in this patient? And so the CP is already in, so you could argue that just putting an ECMO, leaving the CP in as a vent is a reasonable strategy. But this patient also doesn't necessarily require VA ECMO. For us, that's a 19 French arterial, it's antegrade perfusion, it's a pretty different type of loading conditions on this heart. So I just want to leave you with a few messages sprinkled throughout here. So message one is we use our cardiac power output to guide biventricular support. So if the power output is less than 0.6, we're thinking LV support. Even on LV support, if we're not getting optimal hemodynamics, we'll go on and add a right-sided system. So BiV support's been with us for some time. This is the pulmonary artery pulsatility index. So that's your PA pulse pressure divided by your right atrial pressure. We published this in 2012, and this index correlates very well with RV dysfunction, no matter how you evaluate that, whether it's with RV stroke work or by echo. And so when we see this CPO less than 0.6, POPI less than 1.0, this for us is biventricular failure. So typical configuration is a CP goes in and then it's followed by an RP for Bipella support. And this is what the ventricle looked like with the CP in, and then we put the RP in. You've still got some contractile function here. Now we're on Bipella configuration with flows of 3.0 in both ventricles. We're starting to see the filling pressures basically come down a little bit. Cardiac index is up. PA-SAT went to the 60s in the cath lab, now at 48%, about 24 hours, or about 20 to 30 minutes later back in the unit. And we start to look over time as to what happens to the numbers. So the creatinine starts to improve, lactate's coming down, and we see that we're getting good hemodynamic support despite this PA-SAT, which I think people tend to perseverate on. And so, and we're off Levophed at this point as well. So we're on Bipella. I go out of town to go give a talk somewhere, and I get a call at 1 in the morning, 2 in the morning, 3 in the morning. And what they're calling me about is fluid responsive hypotension. So intermittent periods of hypotension, but responding to fluids with an RA pressure of about 10. And so my recommendation is to continue giving fluids, get the CVP up to 15. I didn't hear anything after that, and then after I gave my talk around 11 o'clock, I check in, and a different change in the plan was done. So this is the hemodynamics on the Bipella or the echocardiogram. The decision was made to take the RP out and put the patient on VA ECMO and leave the CP in as a vent. And this is your LV in Bipella, this is your LV on VA ECMO. And so now you can see that the LV is basically at standstill, the device is in place here, and this represents a very hemodynamically different substrate that you're dealing with at this point. And so I think it's really important if we're going to start using the devices just to make sure we understand how they work. So this is how VA ECMO affects your pressure volume loop. So as you can see, the PV loop was here. As you activate VA ECMO, that peak systolic pressure starts to come up in the left ventricle. Your overall arterial pressure comes up beautifully. You get great blood pressure support. But if you're a left ventricle, you're really being asked to do a lot. You're having a high load imposed on you here. So 5 minutes after VA ECMO at high RPMs, we turn the ECMO circuit down, and what we see is that in this swine model, that the LV systolic pressure cannot be generated over 40. The LV at this point has had an ANREP effect, where there's been a load imposed acutely on the ventricle, already an impaired ventricle, and it can't recover from that. So now you're ECMO dependent. And I think that's an important point to keep in mind when you initiate these support strategies. So here's what happened to the patient. CP on transfer, comes in, gets Bipella, creatinine's coming down, lactate's coming down. I go to bed, and then ECPella gets, RP gets taken out, ECPella gets initiated. Numbers continue to trend down, but then over a period of the next 48 to 72 hours, a lot of weird things going on. And then what you see here is the creatinine just going up. It's a massive slope. So AKI with VA ECMO, anywhere from 30 to 70%. post-VA ECMO initiation. That's a very different hemodynamic load that you're now imposing on your kidneys. And then something happens. There's a change right here, and the lactate goes right back up to 10, and it goes up abruptly. So when I checked in after the weekend to see what the heck was going on, I basically found out that the patient been on VA ECMO, Impella CP had been basically turned down to P2, then down to P1, primarily because of continuous suction events on ECPella configuration. So now you've got an Impella that's basically doing nothing in the left ventricle. And the patient at that point had a thrombosed ascending aorta and a thrombus that extended up into both carotids. So when we talk about load imposition on the left ventricle, what this means is that the aortic valve closes. You have a straw across the aortic valve, but if you don't have adequate preload to that ventricle and you're not managing the pumps equally or carefully, then what you're going to have is basically an ascending aorta that's under high pressure, and a clot's going to form. And it's either going to form in the ventricle or it's going to form in the ascending aorta. So if you're going to use these configurations, everything you just heard about today, you have to understand how the devices work, you have to monitor hemodynamics, you have to manage loading conditions, and it all occurs after the cath lab. Just putting it in the cath lab is one thing. That's where the heroics happen. But the real heroics happen in the intensive care units, and that's where you got to partner with your colleagues. So the main thing that was that we've highlighted in publications previously is that LV suction, when you're having to dial down your CP on an ECPella configuration, is primarily due to overall RV failure or profound hypotension. These are all the hemodynamic images of LV suction and what it looks like, LV systolic pressures of 5 until you start to support the right ventricle. The next thing we've also published is that when you start to manage patients with biventricular AMCS, you've got to do a good amount of fluid resuscitation. You just put 2 rockets in the patient's chest, and those rockets require a lot of preload. So we usually do a permissive period of hypervolemia with CVPs ranging 15 to 20, and wedges ranging about 15 to 20 as well for about 48 hours to allow those pumps to allow for adequate circulation and get multi-organ function to improve before we start to diurese and wean. So yes, they came in with BIV failure, but you've got to give them volume in order to allow the pumps to do their job. And the other thing that we published last year is that when you do bipella support, make sure you do simultaneous, not stage support. So what that means is that when you're in the cath lab, you've got hemodynamic equations that suggest biventricular failure. Don't put the CP in and then wait. Go ahead and just put the patient on adequate support, and that could be ECPella, it could be bipella, but if you're going to do something for BIV failure, support both ventricles. Don't do it in a staged fashion. And this replicates what happens in the durable VAD literature as well, patients coming in for BIV failure for durable MCS. And so at the end of the day, would we say VA ECMO an event for all? No. Would I say bipella for all? No. What I would say is learn about acute mechanical support. Learn how to manage acute MCS after you leave the cath lab. These are some examples of biventricular failure that are managed with a bipella. These patients can go home with their own hearts. They don't all have to be transitioned to cardiac replacement therapy with durable VADs or transplant. But what it requires is a lot of management. This is day 15. So it's about a 10 to 15 day slog through the intensive care units after pumps go in. So thanks very much for your attention.